Hi everyone, my name is Joy Marie Ilagan, and today I'll be presenting a case study on cardiovascular disease. Cardiovascular disease is a class of diseases that involves the heart or blood vessels. CVD remains the leading cause of death in the United States during the 20th century due to its shifts in lifestyle and diet. Approximately 1 million Americans die from CVD each year, making up 42% of all deaths. 160,000 of these individuals are between the ages of 35 to 64, showing how widespread CVD is in the population. There are three distinct types of CVD: coronary artery disease, stroke, and peripheral arterial disease. Non-modifiable risk factors are aspects that cannot be changed or controlled. These include age, gender, race, and family history. On the other hand, modifiable risk factors are health aspects that can be changed or controlled, including obesity, high fat and high cholesterol diet, sedentary lifestyle, and smoking. Individuals living with CVD or are at risk can also live with other conditions like hypertension, diabetes, hyperlipidemia, and other already established diseases, making early detection of risk and prevention necessary through pharmacological treatments and lifestyle modifications. Risk assessment are simple, non-invasive tests used by healthcare providers to screen for factors that increase the likelihood of CVD, allowing for early detection and treatment before it develops into a more serious condition. Risk factors for heart disease to be assessed in patients over the age of 20 are family history of CVD, smoking status, diet, cholesterol and physical activity, blood pressure, body weight and body mass index, waist circumference, fasting blood lipid profile, and fasting blood glucose. These risk factors can be used to calculate a global risk score in people 40 years and older to provide an estimate of the 10-year risk of heart attacks and death from CVD. On the right, you'll see data from the CDC showing the percentage of death caused by CVD by race and ethnicity. Non-Hispanic Black adults have the highest rate of cardiovascular disease and related mortality in the United States. To properly address CVD and design a solution, we must look at the economic, social, and cultural factors. For economic, the American Health Association wrote that CVD-related costs are expected to triple to $1.8 trillion by 2050. Already, people are currently facing financial burdens trying to pay for the cost of medical bills, health insurance, medication, and treatment for CVD. A survey from the NHIS of U.S. households in 2011 to 2017 found that nearly half of families of children with CVD had financial hardships relating to medical bills. 17% of families who reported that they could not pay for their medical bills had higher rates of food insecurities and delay of care because of these costs. Data also showed that individuals with private health insurance were more likely than those without health insurance to receive testing. Social health factors can lead to chronic psychological environmental stressors like social community, leading to discrimination and social isolation, healthcare access leading to limited healthcare, neighborhoods and built environment leading to unsafe, insecure housing and lack of access to grocery stores, socioeconomic status leading to low status and food insecurities. These stressors in turn can promote risk to CVD. Finally, cultural beliefs in healthcare systems, diet, and physical activity can affect seeking management for CVD. Language barriers can also hinder effective communication between patient and providers, impacting quality of care. Further, to better understand where we are in addressing cardiovascular disease from a public health perspective, I'm going to walk through a brief SWOT analysis. A strength is that we have many tools for early detection, such as risk assessments, screenings, lifestyle interventions, and other tests to prevent or manage the risk of CVD. A weakness, however, is that there is a high prevalence of risk factors such as poor diet, obesity, high blood pressures, which is very common in the U.S. Opportunity is that there is growing awareness of and public health initiative from organizations like the American Heart Association. Finally, a threat is that the increasing cost of healthcare and lack of access makes it difficult for everyone to have equal access to get the basic screenings. The root causes of cardiovascular disease is a combination of individual, community and environment, and systemic factors. At an individual level, individuals engage in behaviors that increase their risk of CVD, like poor diet and lack of physical activity. Risk is also shaped by community and environmental factors consisting of social and structural influences. For example, many neighborhoods have limited access to healthy foods and grocery stores and are overpopulated with food deserts, as well as high-fat cafeteria foods in schools and unsafe neighborhoods for jogging and walking. Lastly, systemic issues include healthcare inequalities. This consists of low-income areas with no nearby clinics or hospital to get routine checkups, language barriers, or lack of culturally appropriate care like discrimination against race, delaying diagnosis and worsening outcomes. Overall, preventing CVD means more than treating blood pressure or cholesterol. Rather, it means addressing the barriers individuals face. Here are two alternative solutions to reduce cardiovascular disease, both addressing the social ecological model. The first is providing community-based intervention and education. This includes health screenings at local centers, public workshops, counseling, and health campaigns. These interventions have been shown to significantly improve people's knowledge of cardiovascular risk and help modify behaviors. The second approach targets school-based lifestyle interventions. By implementing regular physical activity and nutrition education in elementary schools, the intervention group showed reduction in both cholesterol level and blood pressure. It also increased their understanding of how lifestyle affects heart health. You can see how both strategies align with the socio-ecological model, showing us that health behavior is not shaped just by individuals, but also by their relationships, environment, and policies. At the individual levels, both programs increase knowledge and promote behavioral change. They also involve families and community members as well as healthcare institutions and rely on policy and funding to expand successfully. These two solutions provide a well-rounded approach to help both adults and children. Wrapping up, this is my personal recommendation to what I believe would reduce cardiovascular disease in our communities. First, I recommend establishing recurring community-based intervention. This means setting up regular health screening events that offer free blood pressure, glucose, cholesterol, and BMI checks in easily accessible locations like schools, parks, stores, and community centers. These events should include multilingual support and offer referrals to follow-up care when someone is found at risk. The goal is to bring prevention directly to the people, especially those who might not regularly visit a doctor. Second, we need to expand health insurance coverage, funding, and for prevention. Legislation should support full coverage of cardiovascular screenings without any out-of-pocket costs. We should also be investing more funding into local schools and community programs so that prevention isn't just an individual responsibility, it's a public one. Making routine screenings a standard part of care regardless of income or insurance status can help identify risk early and reduce long-term costs. This slide outlines my 4-phase action plan for implementing community-based cardiovascular screenings and health education. In months 1 and 2, the focus is on planning and outreach. This means identifying high-risk neighborhoods using public health data, building connections with schools and community organizations, and creating flyers and multilingual materials to spread awareness. By months 3 and 4, we move into the building phase. This is where we train volunteers like nursing students or community health workers to conduct screenings and help educate the public. We also work with schools to start preparing nutrition and physical activity programs. In months 4 and 5, we officially launch the program. Screening will be offered monthly to inaccessible community spaces. Alongside that, we'll provide educational workshops and begin introducing the school-based health components. Finally, starting month 5 and beyond, we enter the monitoring phase. This here will track how many people are getting screened and the trends that we are seeing, like blood pressure and BMI. We'll use community feedback and adjust and improve the program over time. The key groups involved throughout the process include local health departments, school districts and nurses, volunteers, and nonprofit health organizations. Together, they form the backbone of a sustainable community-driven solution. To conclude, I want to reflect on Japan's community-based cardiovascular prevention program from 2008. Over a 6-month period, participants received routine health screenings along with support for lifestyle changes. After an 18-month follow-up, researchers found a significant decrease in cardiovascular risk scores, proving that when prevention is structured and consistent, it works. To me, this reinforces something I've seen in both studies and in my community. People often want to be healthy, but they don't always have the tools and access to make that happen. I believe that in the U.S., if we took the similar approach through regular health screenings, school health programs, and community outreach, we can detect risk early and help people make real lasting changes. In my opinion, prevention should not be a privilege. It should be a basic part of public health, especially for communities that are often overlooked. But making that happen requires social support, public investment, and long-term commitment. If we build systems that make prevention routine, accessible, and community-driven, I believe that we can move towards a healthier future for everyone.